I'd like to officially welcome you to our first session in our COP webinar series. And our speaker for today is Sharon Litwin. And Sharon is founder and senior managing partner at 5 Star Consultants. 5 Star Consultants is a national consulting and coding firm that specializes in home care and hospice services since 2003. Sharon is a former ACHC and CHAP surveyor, performing Medicare deemed surveys for 10 years. Sharon has been in the home care and hospice industry for over 25 years. In her consulting firm, Sharon assists home care and hospice agencies in providing quality, meeting regulations, ICD-10 coding, OASIS, increasing outcomes and 5-star ratings, and having providers be prepared for continued survey readiness. Sharon and her staff perform ICD-10 coding and OASIS reviews, CoP, clinical record reviews, mock surveys, and they help agencies all across the country stay in compliance. Sharon is a regular speaker to education companies, state and national associations, and in multiple publications. And with that, Sharon, I'd like to welcome you and turn things over to you.
Thanks so much, Patty. Hi, everyone, and welcome to part one of our 4-part series on the COPs. So if you don't know what I'm talking about, you've been in a hole for the last year and a half and aren't aware that on this past Saturday, our new home health COPs for home health took effect. I was just telling Patty that this week has been such a blur, and it's only Thursday morning, and it is because, you know, I have a consulting firm, and this week in our consulting firm, I do believe in the 15 years that we've been in business, there have been more phone calls and more emails from agencies across the country in a total panic mode, all of them wanting on-site visits next week or serious, you know, one-on-one webinars for them. It has been incredible. So, number one, you guys are doing an awesome thing because you're getting more training. Even if you are just getting your first training, that's where you have to start. There's no reason to panic. You have to just take a deep breath. I was a surveyor for 10 years. I left ACHC. It's been about 4 years ago since I left ACHC, amazingly, simply because of how busy I am and how much I travel already with the business. I was there for 5 years, and I was at CHAP for 5 years before. I know a lot of surveyors, and a lot of surveyors also work for us as consultants. And 2 of our consultants that have been long-term surveyors are out on their first surveys this week. I had asked them about 2 surveyors that are at a client of mine this week, just to say, hey, do you know these surveyors, just to try to see what, you know, the approach is going to be this first week. And both of my consultants / surveyors said they are out on their first surveys and they are nervous wrecks because they have to survey to the new COPs and nothing is clarified and it's such a big change and oh goodness, how are we going to do it? So I wanted to say that to you because literally that conversation was just this morning. And so we all have to take a deep breath, no matter if whatever state you're in, if it's the state coming in to do your survey or an accrediting body, it's new for everyone. And CMS has not clarified a lot of the questions that have been put in to the draft interpretive guidelines. We thought we would have that clarification and the final interpretive guidelines by January 13th. We don't. And so they said that if any of you missed the notice that just came out, maybe the day in between Christmas and New Year's, I think, is that, yes, we know things have to be clarified, but the surveyors will be able to survey to the COPs, and the agencies are, you know, have had plenty of time to be in compliance. so you guys can just go ahead before we finalize them. So honestly, CMS doesn't get how difficult this is to do in a real life agency. For those of you who don't know, yesterday the G tags came out, part of the SOM, the State Operation Manuals. They did assign G tags. So we have all of the lists of G tags, and they did attach level 1 and level 2 tags. Those are highlighted so you can see what those are. They also changed the number of clinical record reviews a little bit that are done on survey. So I'm with all of you. We had gotten them yesterday morning, and I told you I've had hundreds of calls from agencies. So I haven't gotten to do too much with them. But if you have not gotten those G tags with the level 1 and level 2, you'll want to get those. NOC put them out. If you are a NOC member, you got them. I'm not sure if HCAF did. Decision Health, Home Health Line put them out in a listserv email. So a lot of sources you could have gotten them. If you can't find them, if you didn't get them, you can email me and I will be happy to send them to you. Especially if you're coming up on survey pretty soon, you definitely want to take note of those attachments since they are showing level 1 and level 2. Obviously, the goal is, particularly in this first year, to understand that you're going to have a lot of deficiencies if surveyors are truly holding agencies compliant for these new COPs. We all know how subjective that can be, state to state and accrediting body to accrediting body and down to the person to person. But you don't want to be unprepared on those level 1 and level 2s, because that is where you can get your condition level deficiencies quickly. So, you know, as far as I feel these days, if you get a lot of standard level deficiencies, oh well, but don't get condition levels if you can at all help it. If you don't know what I'm talking about with a lot of the terms I've just used, then you may want to email me after class and ask me, because that would mean that probably you're newer to home health and don't know a lot of those terms that have been around forever. So don't be afraid to email me and ask me. All right, so, you know, I always like to start off with things that are hot off the press, because this has been an ongoing project at least since last January for these new COPs. And we've been given information little by little every couple of months. You know, those of you that are accredited, well, you know, you had to wait forever for those to be approved. Some are approved, some are not. We had to wait forever for some clarification on the final rule responses. Then we got the final, or the draft interpretive guidelines right before Thanksgiving. And so it's been very piecemeal, and that's why you being hooked up with HCAF is so critical, so that you can be on the listserv so that you get all of that hot off the press information. So, of course, you know, we'll talk about the key changes, the principles, the details of each condition. I have not changed my slides a lot from the final rule responses, because that is in the Federal Register, and unless the interpretive guidelines overrule something, we do have to follow those guidelines. And so I will talk about some of the key areas of the draft interpretive guidelines that we are being walked back on. Excuse me, I had to shut that blind. That morning sun is right in my eyes. Okay, so of course they went into effect Saturday. I have been teaching this for a long time. It's a very short time frame to prepare and implement. Well, I started teaching this last January, and I still have that in there. I have not changed that because a lot of agencies are not prepared and have not implemented many of the COPs yet. So, you know, my best idea for you today, and then in the subsequent 3 webinars that we do on this, is as you're taking notes, really star areas that you feel you are not yet in compliance, because you want to make a priority list. And, you know, no matter your size, you want to do task forces to be able to achieve each of the priorities as soon as possible. So even if you're very small, there's obviously more than one person in the agency. And so that's when you have it divvied up. One person does each thing, including your field staff and office staff. If you're medium size and up, having task forces with a couple of people on, and so I'm including your field staff. They have to be involved because so much of this does come on the field staff with what they do and what they document. This is our first major revision in COPs in 3 decades. So there's no question that this had to occur. I think that a lot of the philosophy of these new COPs is wonderful. And honestly, it's what I've been teaching for 20 years. Case management models is what I have called it. It's more based on the patient and the patient's team, which means everybody that's taking care of Mrs. Jones. I'm the nurse, Bob's the PT, Sally's the OT, Mary's the aide. That's the example you'll hear me give over and over. That is the team, not part of the agency coming in weekly for a case conference, as 3 agencies said to me yesterday. That's not it. It's who's taking care of Mrs. Jones. Is that team working together and communicating constantly to each other, the physician, the patient, in order to improve Mrs. Jones's outcomes? That is the key and the main philosophy of our COPs. There's nothing bad about that. And to survive in this age of home health and for the future in home health, your star ratings and your outcomes for value-based purchasing, it also says, will your agency be financially viable? But the key thing is that Mrs. Jones will have increased outcomes while she's on home health. And the key outcomes is hopefully her emergent care visits and her rehospitalizations will be decreased. So when you look at it that way, all of the agencies that thought that these would still be delayed, how would they be delayed? Because legislators, think tanks, everybody reads these and says, well, of course that's what home health should be doing and should have been doing. The problem is, you know, the group of people that wrote the COPs, I'm not sure that any of them actually worked in home health to see how difficult, or, well, I won't say impossible, but difficult some of this is to implement as a process. So that's what we'll talk about a lot as well. And honestly, we are doing so many on-site visits and long webinars, sessions on the phone, I should say, with agencies to say, okay, here's this issue. What should you do as far as education, process change, you know, review to be sure you're in compliance? And that's what each of you have to do in your agencies in order to ensure that for your first survey, for your first ADR, you don't run into a lot of difficulties. This is still the easiest. Well, maybe yesterday's changes this slide because our G tags are always so important. But what was sent out was not the full state operations manual, because that won't be sent out until the final interpretive guidelines. So this is a link that if you don't have an easy link to get to the actual COPs, this is it. But even out of this, it's 88 pages instead of 388 pages. And the first pages until page 75 are what I use to really teach, because that has all of our responses to the proposed COPs and CMS's final rule answers. And then it has a lot of cost information and many more statistics. But 75 to 88 is the bottom line, our COPs. For now, you can combine that with the G tags we got yesterday. Now, obviously, I had updated this before that said our final won't be out until December. Actually, but we got the draft IGs in right before Thanksgiving, and now, as I said, our final ones are delayed even more. So if you're not familiar with the interpretive guidelines, those are very critical, because when you print off the COPs, you want the version that's called the State Operations Manual. You can't get that yet. But then it has our COPs, and it has interpretive guidelines, which is information for surveyors to use. Surveyor, what do you look at when seeing if an agency is compliant in this standard? What are your probes? In other words, what questions do you ask? What documents do you look at? Do you look at this on a home visit? Do you ask questions to staff? So it's critical for you to follow the interpretive guidelines. In addition to that, it gives some clarification, which is very important, because the COPs today, or it isn't today's COPs anymore, yesterday's COPs and these new COPs are not always real clear of what does that mean as far as implementation and what a surveyor expects to see. So those interpretive guidelines are critical, and that's what you should use. It's so confusing, because it won't ever be called, the COPs or whatever. You have to download SOM, State Operation Manual, to get the COPs with the interpretive guidelines. Like I said, don't Google that today, because we don't have our final interpretive guidelines yet. So for now, you're still going to use this link and the attachment yesterday that was put out with the G tags. This talks a lot about the philosophy. Interestingly, that second bullet or quotation, the COPs are the minimal health and safety standards the home health agency must meet in order to participate in Medicare programs. Well, I don't know about you, but I think that these are pretty high. I don't think that they are minimum. If you are accredited, you do have some things that are more elevated, but honestly, with the COPs the way they are, it's not a whole heck of a lot different. It is, a difference in maybe the survey process and the accreditation standards, however. Patient-centered care. That is a very key area that is the theme throughout these COPs that are very important for you not to fluff over, because your staff in the field have to ensure, and Mrs. Jones's team has to ensure, that this is patient-centered care while at the same time following physician orders. Interestingly, they made a big deal about how much they streamlined our requirements. Well, you can be the judge of that. I don't agree. So, not only is it patient-centered, not only is it outcome-oriented, but it's data-driven. Patient-centered, data-driven, outcome-oriented. Patient-centered I talked about. Outcome-oriented I talked about. Data-driven simply means we're going to use outcomes from CASPR in addition to many other areas that we work with in our industry. Outcome-oriented, that means that team, my team, taking care of Mrs. Jones, when we start her out, we're going to say as a team, we're going to work on improving Mrs. Jones's pain we're going to work on improving her meds and improving her ambulation. So let's say those three are what our team together has decided to do with Mrs. Jones caregiver, Mrs. Jones patient selected representative, if any, and Mrs. Jones's physicians all agreeing to. That's what it's about. Now, you take that further and extrapolate that to your 100 patients in your agency. Your outcomes then will be improved because each team is working closely together to improve certain outcomes. So it definitely is a win-win situation. I'm a total believer in all of that. But now we have to talk about how you're going to implement all of this. Continuous integrated care process across all services. Now, over and over, you're going to see about how your contracted services must be included in everything that are in these COPs. That is not different, but boy, is it being enforced now. So let's say in my team, Bob the PT and Sally the OT are from XYZ Therapy Company. Well, it is not acceptable for me, the RN, and you, the Director of Patient Services, not to know when Bob and Sally are seeing Mrs. Jones, not to have an advanced calendar of when they're making the visits, not to have information on those therapists as far as licensure and competency and orientation, etc. Not to have Bob and Sally involved in your QAPI program, and not to have Bob and Sally involved in working with me, the nurse, and Mary, the aide, to say what outcomes are we going to increase for Mrs. Jones, and not to constantly communicate with us and document that communication. So everything we say, and you will hear it over and over and over again in these 4 sessions, that subcontractor has to do all of this just like your own staff. If you're I know Florida has more aid subcontracts than I see across the rest of the country. So the same goes if Mary is from a contracted company. So you think case management. I have taught case management models to Florida, HCAP, and before when it was called, what was it, HIF, for years. I've taught case management models in sessions and done it at a lot of clients in Florida. I called it case management. That's what I'm talking about, is Mrs. Jones's team, and exactly what I'm talking about. You may want to call it your interdisciplinary care teams. You may want to call it a care management model. Whatever you are calling it is fine. Pretty much these new COPs talk about the interdisciplinary coordination of care, but that is a model where teams are assigned. It's not just you assigning visits every morning sporadically or at random. Outcome oriented, you make quality improvements through your QAPI. The things that they eliminated are the ones that are not relevant to improve patient outcomes. And you'll see all about patient rights today. So what's included? You have to give, I'm not going to go over this all in detail because we'll hit it later, but this first one is in section 2. You have to give written, some of it's in patient rights, but you have to give written information to the patients about upcoming visits, med instructions. That's all what we do already. A lot are not compliant in that, however. Treatments administered and any instructions for care that the patient and caregivers perform. Our industry is weak on doing that, and you have to be doing that as of this past Saturday. Have the integrated communication system that ensures patients' needs are identified and addressed. Care is coordinated among all disciplines, and there is active communication between the agency and the patient's physician. Now, one of our top deficiencies is that we do not notify physicians timely when there are changes. More so even than that is the cause for many ER visits and rehospitalizations. We'll talk more about that next week. However, a very simple, quick example is that the team that's on Mrs. Jones, the PT is out in the third week of care. When Mrs. Jones is walking with the PT, he notices that her ankles are more swollen today and that she is more fatigued and says she's getting more winded. So he documents that in the EMR in his visit note, but he does not communicate that to anybody. Well, one of Mrs. Jones's comorbidities is CHF. Those are 3 glaring signs of a CHF exacerbation that are early. If instead Bob said, oh, okay, I'm going to report this to the team to see if anyone else, including Mary the aide, has noticed this, and me, the nurse, is going to say, ooh, I think I'm going to go make my visit tomorrow instead of 2 days from now, because that sounds like she may be having an exacerbation. And or I'm going to call her or her caregiver or her representative to see, or I'm going to call the physician and report that and get an extra visit. That alone can save a CHF exacerbation. Maybe all I get, just simple example, the doc says give her an extra dose of Lasix today, end of story. That's what we're talking about. So when you hear it in those terms, of course we have to do that. That's what we are here for. Our CoP program we will talk about a lot later on. We are going to, I think it's in session 3 or 4, but you have to have CoP going now. If you're accredited and you're compliant with the accrediting standards, you're pretty much there. If you are Medicare and ACA comes in, you have to make sure that you have your plan, your quality indicators, some based on your Casper analysis, others based on what you find in your survey, in your agency as high volume, high risk, and problem prone areas. You have to be collecting data. Your PIPS, your Performance Improvement Program, is the only thing, or Performance Improvement Project, I apologize, is the only thing that has a phase in. We don't have clarification on that yet, because in the one memo that came out a month or 2 ago, they said, no, they're not giving a 12-month phase in now. They're giving a 6-month phase in since they delayed the COPs. So you want to be starting your PIPs now as you're finding issues, because if in your quality indicators, your auditing and monitoring shows you have a problem, well, you start that PIP now, you don't wait. But like I said, join us for the next sessions, and it's either section 3 or 4, we'll be talking a lot, mostly about CoP. And in that section, we'll get into infection prevention and control. If you don't have a good infection education program and a good infection surveillance program, you really need to put that together this week. Skilled professional services we'll talk about, agency administrators, so all this will be covered in the 4 sessions. This is costly, there's no question. Last year, I haven't changed these numbers because I haven't seen that NOC has. Quite honestly, okay, now, remember, if you're an agency that just started up with if you just started up, you're paying a lot more than this. But if you're a small agency with under 20 patients, well, you'll pay less than $30,000 maybe. If you're a humongous agency with lots of locations, just keep multiplying that $30,000. But this just shows you, if this is your first training and you've done nothing else, you are behind the 8 ball, because it has been costly to prepare and implement and assure compliance. A lot with getting training, as you're doing now, train the trainer, everybody in your agency and all your contractors to be so well trained. Process implementation. So you have to take a lot of non-productive time to do these things, then to train them, then to audit them. so it is costly. One of the reasons that a possible delay was expected and too many agencies thought would occur, but of course it didn't. This is the list of our 16 conditions. Keep in mind they are in effect from Saturday, this past Saturday on. Okay, so you do not have to do a PAC or an annual agency eval anymore. If it was due before January 13th, you had to. So if it was due before then, you should have had a PAC and annual agency eval by January 12th. If you were not due, you don't have to do them anymore. So yes, that is a woohoo. That is the two conditions they deleted that were nothing more than busy work. So that's great. The other ones, they said that they deleted quarterly record reviews. Don't believe that, because we're going to be doing that under CoP. And 60-day summary to physician, don't believe that, because we have to show a detailed continuing need for home health on our research and our rocks. And so that is no less than a 60-day summary. In addition, you're communicating to the physicians a lot more. So, you know, maybe the actual term has gone away, but it is still there. Subunits eliminated. I'm not going to spend any time on that because there are so few. I have one client in Colorado that has a subunit, and I haven't heard from anyone else. I've heard there's only like 20 subunits in the country. If you have one, you'll want to look at the slide that I have that gives you instructions. All right. Now the basis and scope, this is subpart A before we get into the nitty-gritty. This just says, if you want to do home health, you have to participate in the Medicare program. If you want to do any Medicare, Medicaid, and then as we know, a lot of insurances require this as well. You can still be a private duty agency in states that do not require you to have follow the COPs. Many states do. I don't think that that is the case in Florida, but I could be wrong. So if you are private duty, you want to check and make sure that with ACA, they have a separate private duty license. I think that they do. And this says that, you know, we have to have survey activities occurring to make sure that you're meeting these these conditions to participate in Medicare. The branch office, they have not changed significantly, but they are more so enforcing it, that this parent agency must supervise and have administrative control on a daily basis. Too many branch offices have been found to be in very bad shape with very little contact with their parent agency. So CMS is saying to surveyors, you will check this even more. This has been done a lot over the last 3 years. In fact, some states like California, there are surprise visits to the branches, bottom line, to see if it is a functioning location. But now this is going to be looked at a lot more in surveys for your branch offices. So expect more on-site visits to your branch offices. A lot of times up until the last few years, when surveyors would make a visit, they would go to the parent, but they would not go to the branches. They would just simply get charts sent down. So you're going to be seeing more visits. But more than that, how is your parent supervising on a daily basis to exercise adequate control and supervision and guidance for all branches under its leadership? Doesn't mean that the administrator and DPS has to be there daily. There are many methods to do that, by EMR, by CoP, by weekly conference calls, etc. This is the elimination of subunit. In November 17th, we finally got some options and a little bit what to do, although I will say that my Colorado client is still not making good progress, although as of January 13th, her subunit in Longmont, Colorado is no longer in existence. It has to be a standalone cert, so it is a challenge if you have one. 4A4.2 are definitions. There are some changes in advance. Well, you know, what's very important is that this added, the agency must complete the task prior to performing any hands-on care, which we knew, or any patient education. And in patient rights today, that is very important. Quality indicators are what you are monitoring in your CoP program, and they have to be written a certain way. Representative. So we're going to talk about a lot in a bit under patient rights, but I'm going to say it here because people get confused. The legal representative has not changed. That is the court saying somebody is a guardian, a trustee, a conservator, etc., because the patient is not competent to make their own decisions. That always has had to be in advance, and a lot of agencies have been non-compliant in that. I would recommend you do not be non-compliant in that. It has to be in advance. But what has been added is a patient-selected representative. The patient can say yes or no to having one. That has to be declined thoroughly, declined and documented thoroughly if they do decline. If they want a patient-selected representative, that means that every time there is anything happening with the patient, for start of care, for initial evals, and then after any changes and revisions, that the clinician has to ask the patient if they want their patient-selected representative to be involved before they do it or told after the fact. That has to be documented as declined, and you have to do what the patient wants. So if Mrs. Jones's husband lives with her, they're both elderly, but he is her caregiver for this exacerbation, but their son, Steve, lives 10 miles away. Mrs. Jones says, yeah, we want Steve to be our patient representative because we don't always remember things clearly. He comes down in the evenings after work about 3 times a week. Well, you have to see if she wants him here for that start of care visit, for that initial eval visit. If she does, you can't do anything. And so you may end up having to call the doctor and say, we couldn't do this visit timely to your physician order because we have to reschedule it for when Steve is there. Also, let's say Mrs. Jones's wound care changes. You have to say, do you want Steve involved before I teach you and start this new wound care? So all along the course of the home health admission, every discipline has to do this. If Mrs. Jones declines, you have to document decline. If she says yes, you have to arrange it so that this is done. So when we get to patient rights in about 2 minutes, that's what we're talking about. Verbal orders, not too much has changed. They took out bylaws. That's good because especially a lot of agencies that are small or in huge systems have no idea where the bylaws are or what they are. I don't, just ignore where they said they took away supervision in home health agency. That's pretty silly, isn't it? Okay, so 4A440, this is all in subpart B now, and this is the big part. This has not changed, the condition on OASIS. Basically, the only things that patient rights takes really long, so I'm not going to read to you stuff that hasn't changed. In Standard A, the encoding and transmitting of OASIS data. This is within 30 days of completing the assessment. Well, that changed about 5 years ago, but keep in mind that our COPs had not been updated. It had said 7 days, I believe, and that's what it had always been up until about 5 years ago. Just remember that QAS, Quality Assessment Submission, that started in the final rule about 2-3 years ago. If you miss over 30 days in whatever the threshold is, every year the threshold goes up, and honestly, I haven't kept up on what that is. You should know that if it's at a 70% threshold now, it means that if 30% of your OASIS are over that 30 days, you get, I think it's a 2% decrease in reimbursement for the next year. So you want to make sure your process for submitting timely OASIS is very timely. Of course, the decoding, you have to do a test transmission as always if you are new, but you have to be hooked up with the QIES ASAP system now, not with the individual states that OASIS was sent to. That started with OASIS C2 a couple years ago. If you're on an EMR, they are the CMS OASIS contractor that sends it to that ASAP system. And they finally took out the reference to the phone connection, which had been in there since OASIS started. And then the data format has not changed. 484.50, there are some, not a lot of changes to OASIS this January. However, there is a big one about collaboration with the one assessing clinician. That is key because they finally said that, yes, the one assessing clinician is able to get information to revise the OASIS from the others on the team. I know most agencies had always been doing this, but that was truly non-compliant. Now that is allowed. We don't have time for me to get into that thoroughly, but that just was put out in the last week. 484.50, patient rights. Okay, so way back last January, Bill Dombey and Mary Carr from NOC did the very first COP training when we first got the Federal Register. And Bill said right then that, you know, a lot of information there, but patient rights is the greatest change and the greatest amount of work. I do totally agree with that. However, I add a secondary one, and that secondary one is the big clinical condition, as I call it, because it's a mouthful: care planning, coordination of care, quality of care. That is the big clinical condition. So I think those two conditions are the trickiest. Okay, so we have 6 standards: notice of rights, exercise of rights, rights of the patient, transfer and discharge, investigation of complaints, and accessibility. I won't get into all of these comments and responses. You may want to read them because it justifies what they're doing. That one doesn't really clarify it. It just that we all said this adds so much to what we already do, and they said, no, we don't think it does. So A, the notice of rights is big changes. Provide the patient and patient's legal representative, if any, the following information during the initial eval visit in advance of furnishing care to the patient. So a lot of key words there. Written notice of the patient's rights and responsibilities and the agency's transfer and discharge policies. Written notice must be understandable to persons who have limited English proficiency and accessible to individuals with disabilities. So if you have not already complied with the D standard that we'll get to soon on transfer and discharge to change your policies, and if you haven't put them in your patient handbooks for admission yet, you need to do so. If that patient, and then we'll get a lot into how much has been added to the English proficiency and accessibility with disabilities. This is if the patient has a legal representative. This has to be done in advance. You can't have a conservator in Texas while you're in Florida and say, oh yeah, we can't get to them yet, but we started care and we put it in the mail. No, that's not allowed. It never has been allowed, but now it takes a much bigger enforcement in how the COPs are written and what the final responses and draft IGs say. You have to also give this patient and patient's legal representative in advance contact information for the agency administrator. including administrator's name, business address, and business phone number in order to receive complaints, and the OASIS privacy notice, which hasn't changed. All right. This explains what I had explained to you before, but this is one of the biggest areas that agencies are still unsure of, that the legal representative will get to. There's a standard on that, and that's just the court doing it. The patient's selected representative does not have legal healthcare decision-making authority. The patient may choose to decline the provision of notice of rights to a patient-selected representative. What that representative is that the patient determines the role of the representative to the extent possible. This is the kicker that shows it is not just at start of care. The patient may choose to involve or not involve the patient's selected representative regarding every interaction with the agency. We expect an agency to document in the patient's record that a patient declined to have a copy of the notice of rights provided to the patient's selected representative. We believe explicitly allowing patients to choose whether or not the info provided to the patient's selected rep will give patients greater control over their care. So that is in the legal writing telling you what the final rule response has, and the draft did not change that. I'm sorry, I am hearing a beeping, and I wanted to make sure I wasn't disconnected from you, but it looks like I'm still on.
You're still good, Sharon.
Thanks, Patty. Okay. Now, obtain a patient or legal representative signature confirming he or she has received a copy of the Notice of Rights and Responsibilities. Provide verbal notice of the patient rights and responsibilities in the individual's primary or preferred language and in a manner the individual understands, free of charge, with the use of a competent interpreter no later than the completion of the second visit from a skilled professional. So what this is talking about, you have to give that written notice of rights, transfer, and discharge OASIS privacy to the patient or legal representative in advance. But if you don't have an interpreter set up yet, or you don't have a TTD line set up yet, whatever, you can do the detailed verbal notice later and still start the care. But it has to be no later than the completion of the second visit from a skilled professional. So I'm the nurse, Bob's the PT. I need to set up an interpreter. I did my care because I did all the paperwork and I had the signatures and all of that, and I explained everything, but they don't really understand or can't really hear me. Now, I have to do that second visit before Bob does, or Bob has to do this whole verbal notice. So, in other words, if I'm going today at 3 and Bob is scheduled for 8 a.m. tomorrow morning, and I'm having to go back tomorrow at 3, that ain't good because I'm waiting for the interpreter or whatever. I have to have that done before Bob goes in. So throughout patient rights and other conditions, there are a lot of timelines, deadlines that are too tricky to remember. I have been teaching this, writing policies, doing webinars, on-site seminars, and with clients for a year. So I know these COPs well. I can't remember all of the time deadlines. So you have to make yourself a chart of all the deadlines and who's responsible for tracking everything. Provide written notice of the patient's rights and responsibilities and the agency's transfer and discharge policies to a patient's selected representative within 4 business days of the initial eval visit. So you can see if Mrs. Jones said, yeah, we want our son Steve to be our patient selected representative, We have 4 business days to get him that information in writing. Now, if the patient says, I don't want to proceed without him here, that's different, but that is another time frame. Now, they don't expect that we're going to have a translated patient rights document to every native language before care. Understandable doesn't mean expected to be written in every language. That would be impossible these days. A general understanding means the patients achieve a grasp of the explanation of something and not necessarily verbatim written translation. But agencies are expected to utilize technology, interpreting services, other resources for oral communication, etc., prior to the completion of the second skilled visit. They give you a lot more information about how much they want. I loved what they put in that second paragraph. Agency staff members are not required to read the notice word for word to the patient. Rather, staff members have the flexibility to provide comprehensive and accurate summaries of each right in conversational language and tone in order to engage patients and representatives in this discussion. I really encourage every agency to go over that with the staff, your staff, in services on patient rights, because this is what they expect to be done. They don't expect a 1-second blurb from the clinician and then sign here, and it's in your patient handbook. This is what they expect. All right, so again, but it's tricky. If a patient has a legally appointed or designated rep that has health care decision-making authority, the agency must provide the notice of patient rights prior to initiating care. Providing notice to the patient's selected representative that does not have legal health care decision-making authority is not always necessary prior to the initiation of care. Why they say not always necessary is because if Mrs. Jones says, yes, I want Steve here, then it is. All right. So we went over the key changes a lot. Both verbal and written specify timetables, notice of what to do with an authorized patient rep, how to communicate the info. Your policies and procedures have to be, our patient rights policies and procedures at 5-star have changed dramatically, as well as the written notice. And education is so key, but that is true on everything. B, exercise of rights. This is the legal authority. This is how you get a legal rep. It's through a court. Hasn't changed. You can read through that if you're confused. C, rights of the patient. There's a whole lot that are as is now, and there are some new ones. So we'll go over the new ones. The number 2 new, not a big deal because we didn't have under free of verbal, mental, sexual, physical abuse, neglect, and misappropriation of property. They added including injuries of unknown source, and they added that in several things in the COPs. But honestly, a lot of the things that we report that we suspect may be abuse or neglect is unknown sources, because that's why we're reporting it. So I don't think that's a big change. Making complaints. Jump down to Roman numeral 6, expected outcomes of care, including patient-identified goals and anticipated risks and benefits. This is huge. It's that theme that I talked about. You're going to see this theme carry through to the plan of care, to the patient assessment, and on and on. So the patient has this right to know what the expected outcomes of care are, be involved in their patient-identified goals with what risks and benefits there are. Of course, this has to be explained, and this has to be documented. And then, of course, any factors that could impact treatment effectiveness, we would already say, well, yeah, but that is new, and I'm not sure that's always done. 5 is very new. Receive all services outlined in the plan of care. This talks about ongoing updates. So a lot of us commented on, well, what are you talking about? How often and for what? What they said was, the intent is to assure that patients can be informed about and involved in establishing and revising their plan of care as a whole. We believe the patient has a right to be involved with all facets of the care they receive, and it's the agency's responsibility to discuss that level of involvement the patients and their reps want to have. This includes how much the patient's able to understand and the extent they want to be involved in the development and updates to the plan of care. And you have to make all reasonable attempts to respect the patient wishes. This is all throughout. All right, this says you don't have to give them a 485 in the home. However, you have to give them information. You have to give them information on meds and visits and all your treatments and all your procedures and anything that changes. However, if you give it in our complex 45, is that patient going to understand that? No. So that's why you can give it in a different format. This is more about that just because of time. We're going to move on. You can definitely read it. Clinical record, well, the last condition we'll go over has a lot of information about timelines and what to do with clinical records. If a patient has a payer source change, instead of 30 days or whatever your policy says, now the agency must advise the patient and representative, if any, of any changes as soon as possible in advance of the next home health visit. So you can't make a visit without first talking to them and having them do a new financial consent form before the next visit. So again, you have to have that as a tight process. Of course, this is our ABN laws, and this has not changed. It's just been clarified or put in writing in our COPs. In advance, receive proper written notice in advance of a specific service being furnished if the agency says it isn't going to be covered, or if they are reducing ongoing care. That hasn't been already explained and is in the plan of care. 10 is new. You have to advise the patient of names, addresses, and phone numbers of the following federally funded and state-funded entities. Now, this is a trick that serves the area where the patient resides. This isn't where your agency is. So if you have a huge territory and you have more than one of these organizations in your territory, then you have to have separate handbooks with different information in them for where the patient lives. Agency on Aging, Center for Independent Living, Protection and Advocacy Agency, Aging and Disability Resource Center, and Quality Improvement Organization. A lot of agencies have said to us, oh my God, we can't find these, we don't have time, can you find them? I've literally had to take one of my assistants and have them spend a half a day on Google going through looking for all of these in all of the territories that an agency covers. So that's what you can expect to have to do if you haven't done this yet, but it is important to do right away. 12 is new, be informed of the right to access auxiliary aids and language services. We'll get into that as a whole standard. D is transfer and discharge. Okay, so we have a standard on this in patient rights, and we have to give these in advance to the patient and the patient's legal rep, and within 4 business days to the selected rep. So what it is not new as far as when we can no longer meet patient needs based on acuity, as long as the physician agrees with the agency, and a safe and appropriate transfer has to be made to another entity when they exceed our needs. If the patient or payer will no longer pay, if the goals have been met and the physician and agency agree, if the patient refuses or wants to be transferred or discharged, the more detailed change is that discharge for cause. So before you discharge a patient for cause, that means that, in case you don't know, the patient or other people in the patient's home Their behaviors disruptive, abusive, uncooperative to the extent that delivery of care to the patient or ability of the agency to operate effectively is seriously impaired. So this also includes unsafe things for your staff. First, of course, you have to advise the patient's rep, if any, and all physicians issuing orders for the home health plan of care, and the patient's primary practitioner or other healthcare professional who will be responsible for providing care and services after discharge from the agency. So those are a lot of people to contact before you discharge for cause. Of course, you make every effort to resolve the problem before. That would include case conferences with the physician, with the caregivers, with the reps, have an MSW go out to the home, et cetera, et cetera. Provide the patient and rep, if any, with contact info for any agencies or providers who may be able to provide care, and document all of this. What did you do to resolve the problem, and how did you do this? This is where a lot of agencies fall down in this area. Of course, if the patient dies or ceases, the agency ceases to operate. So this, again, just reiterates that you have to provide physical or electronic documents for the patient's keeping of the reasons for discharge or transfer, and they have to go to the legal representative in advance or the selected representative, and they have to be communicated to the caregiver as well. You cannot do this for staffing purposes. Now, I would say to you that as they said that, we don't agree staffing changes is an appropriate reason for patient discharge. Well, it certainly is an appropriate reason for patient transfer to another agency. So don't forget that, because if you have no staff, it is unsafe for you to keep that patient. You can't do this for just a face-to-face alone. Here's where they talk about that as well. They think face-to-face is easy for us, and so that should never happen. You can read that, as well as with the Impact Act. Obviously, we're not going into that today, but there are many more transfer and discharge policies for post-acute organizations under the Impact Act, which that's what it is. And the ones for us for now that are critical are put into our COP. E-standard investigation of complaints really hasn't changed. They added injuries of unknown source. Just be sure to document well and document the resolution of the complaint. That's where most deficiencies come from. Accessibility is new. Information has to be provided to patients in plain language and in a manner that is accessible and timely to persons with disabilities, including websites and provisions of auxiliary aids and services at no cost. This is all under the ADA that we have to follow in order. Actually, we go through the Office of Civil Rights when you are first certified as a new agency, and then every time you have to redo an 855 when they tell you to. And so we have to follow all those laws. A lot of this had not been in the COPs 30 years ago, of course. So the oral interpretation and written translation, of course, is also at no cost. They really get into what they want you to do, and our draft IGs have even more specifics on what you are responsible to do for the patient. I didn't put them in here because we don't have the final IGs yet, but you know, you have to go over what we do now in many cases. Of course, qualified interpreters, of course, in as many languages, as you can get. Large print documents, Braille, digital versions of documents, audio recordings. Now, I know that most agencies do not have Braille documents and digital versions and audio recordings. So that can be a challenge. And then, like I said, our draft interpretive guidelines, they put even more areas that you should have as resources. So this is a very big deal. You know, have to make sure that interpreters are very trustworthy and good and reliable, so no little kids, and, you know, depends for family and caregivers. So you just have to really beef up your accessibility. All right, so that was a lot on patient rights, as you can see. That takes not only initially updating policies, updating forms, getting those approved, educating to your clinicians, not just the ones at the start of care, but all your clinicians, and then setting up processes in your office to be sure you're meeting all of these time frames and how your process is going to work because of that. That intense coordination of care between the team and the office. And then doing home visits to ask these questions as a surveyor must do. Then auditing to be sure this is all in place. This is very big and very important. And with getting condition level deficiencies, if you have a few standards deficient under any condition, that flips very quickly to a condition level deficiency. And I'm just looking at some of the highlighted tags under our G tags in patient rights, patient participating in care, patient and representatives. I apologize, the phone fell down as I reached for the handout. Patient and representatives participating in care, investigation of complaints, treatment or care, resolution of complaint. It looks like those are the only highlighted ones, but if you get a lot of conditions in the other ones, that can quickly flip to a condition. Organization and administration of services is 105. That doesn't change too much. It's primarily budgeting and the administrator. Here are all of the standards. Under governing body, you know, a lot of it is the same. They just put CoP in there. They took out PAC. This kind of explains who your governing body is. It has to be legal authority. There were a lot of questions about that. Now, the administrator always has to have been appointed by the governing body, but has never had to report to the governing body. Now the administrator must report to the governing body, as well as the governing body is responsible for all day-to-day operations of the agency. Now, if you are in a huge hospital system, that is really tough, right? But your org chart has to show that that administrator is reporting up to the governing body in some way or the other. If you are small, that's probably not too difficult. If you're privately owned, it's very easy. But you have to keep that in mind because that will be looked for. The other thing that hasn't changed and has been in ACA regs forever is that qualified pre-designated person in writing assumes the same responsibilities and obligations and is approved by the governing body. There's more changes on administrator under personnel. The administrator or pre-designated person is available during all operating hours. Can be by phone, but you can't have, as we see so often, oh, they're at work in the hospital. I just had a small client out in California. We were trying to reach her to return her issue that she wanted to start ASAP, and she was working in the hospital for a 12-hour shift that day. That is not allowed. See, your clinical manager, you know, they say it's a new one, but it's really not. It replaces the supervising nurse. We all have had clinical managers. We might have called them DON, DPS, DCS, supervisors. The key is you have to have one or more. And one or more. And of course, they have to be qualified. you can just do what we did in our policy manuals and org charts, is put DPS/clinical manager and change all the supervisor names to clinical manager. It doesn't really change what we do. Here are the areas that they have to do. Not too much is different. This is information, if you need it, of when you can have just one doing it all versus several having a split caseload. You still have to have a DPS because somebody has to be overall. And then, at least in my opinion, this says you don't, that they would all report to the administrator. Let's see, this says you can have one position in rare cases, administrator/clinical manager. That's if you're a startup or very small. This says that we think that, our comments were, we think that a therapist or social worker should be able to do this role as well, and they said yes. So you can have a therapy manager now be called clinical manager as an example. But that gives you a lot of the clarification on some of the tricky areas of clinical manager. The reason why they put this in here is they think that we've never done anything like a clinical manager, and that's why we have so many deficiencies based on patient care and coordination and implementation. But that again shows that I don't really think a lot of the people that were writing these understood home health, because of course every agency already has a clinical director, clinical manager, no matter what they are called. A lot of agencies have several, no matter what they are called. And honestly, that's not the reason we get so many deficiencies, but that's why they did that. The parent branch definition I talked about, or relationship I talked about before. Services under arrangement, there is not a lot of change. I shouldn't say no change, because if there are any contractors that have ever been debarred or from participating in any government program, had its Medicaid or Medicare revoked, etc., you have to know that, because you cannot contract with them. And many agencies on their contracts, they do not do an OIG check, etc., and you must do those kind of background checks on whoever you contract with. Everything else is the same, but man, you better involve them in everything in your agency now. Services furnished only changed in that it changed from in a place of the patient's home to a place of residence used as the patient's home. All right, sorry, that's my alarm saying we are almost out of time. Outpatient physical therapy and speech language pathology. Very few agencies do that anymore. When I first got into home care in 1983, some did. Not a lot do anymore. I don't know why then they put this under our COPs now for home health, but they did. Institutional planning. Well, there's budgeting stuff. You have to do an annual budget. You have to have all incomes and expenses. You don't have to have a line item, however. And you have to do a 3-year capital expenditure program. Most of the time agencies say no capital for next year and the 2 years after, because we don't have a lot of that anymore. But the preparation and plan of a budget, you have to have a budget committee now. This budget committee has to consist of representatives of the governing body, administrative staff, and if you have medical staff, which of course a lot of agencies don't because we're not required to. It has to have a person from the governing body, let's say your administrator and your clinical director, and then it has to go to the governing body. And it's reviewed and updated at least annually by this committee and under the direction of the governing body. Most agencies do not do that, so you're going to want to be sure to set up that budget committee, have somebody on your governing body be on it, and make sure you're doing that. It's easier for small agencies, it's harder for the huge health systems, but you have to figure out any kind of method to do that. 484.115 is personnel qualifications. Well, if you are an administrator who is not a nurse or a physician and you don't have an undergraduate degree, you are grandfathered in. You can stay as the administrator of your current agency. However, if you leave that current agency for whatever reason and you want to get a job as an administrator in another agency, you have to get an associate's degree first. That associate's degree does not identify what it has to be in. It has to be an associate's degree. So that is the big deal. So prior to January 13th, you just had to be a physician, a nurse, or has training and experience in healthcare admin, or at least 1 year of supervisory experience in home health or a related healthcare program. Now it is a licensed physician, registered nurse, or holds an undergraduate degree and has experience in health service administration with at least 1 year of supervisory or administrative experience in home health care or a related healthcare program. That is important. There are a lot of organizations where maybe an office manager who has been so good in running the agency but never had a degree, worked their way up from clerical, has been an administrator. I know of one right now that is so good and has been an administrator forever, but never got a degree. If she leaves where she is, she can't be an administrator at another agency ever unless she gets an associate degree. Clinical manager, well, I talked about, but our COPs are convoluted, or I should say fragmented, because they don't have everything all in one place. We just heard about a clinical manager and an administrator in organization and administration. Now we hear the rest of it in personnel. So you have to read the whole COPs and your policy manual. If you have one that's separated by COPs, you can miss stuff. So like, for instance, our manuals, we don't do that. We put an HR chapter, and that has all of it together. You have to do that kind of thing or you may miss things. Anyhow, here is where it talks about a clinical manager can be a licensed physician, physical therapist, speech language pathologist, OT, audiologist, social worker, or a registered nurse. So interesting. So 3 decades since they changed this. In all my millions of years in home care, I have never heard of any of us ever using an audiologist. And yet they kept audiologists in for all these things. Everywhere I go and everywhere I speak, I always say, please let me know if you know any audiologists that's in home health and what exactly they're used for, because I have no clue why they kept that in there. All right. The only other things they added in personnel, they did not increase the level. They added doctoral degree to social worker. I don't know why, because, you know, we're still required to have a master's, and obviously if you have more than that, that's fine. And the same for an ST, which is now, if you're not calling them SLP, it's not speech therapist anymore, it's speech language pathologist, primarily because of their level of education that's required. They have to have a master's, and now also if they have a doctoral, of course, that's fine. There were no changes to the others except for AIDS, and that is in one of our next sessions on AIDS services conditions. So to end, you can see that they are very patient-centered focused on outcome improvement, on coordination of care. We're going to talk about that so much next week. Patient rights, if you haven't been working on that for a long time, you have to put a task force together, and you have to get this in place pronto, because all of this had to be in place by January 13th, and it is a lot. Of course, subunit, you have to get on that, because basically, if you have a subunit and haven't done anything, you don't have a subunit anymore. You have to stop doing any care out of it. administrators without degrees, clinical manager. So this was packed full, but you're going to see in the I have it broken out into 4 90-minute webinars. They are all packed full. And in that time, we don't even have a lot of time to talk about how you implement these things. So this can just give you a taste of how much is involved. Hopefully this is the 10th time you're hearing all this.